Well, I want to thank everybody. I know it's getting close to the time. You guys have been waiting for quite some time. I'm going to try to encapsulate in an executive summary some of the commentary from the other discussions into this to say, okay, now we even have an idea about how trauma can influence the central nervous system, the plastic brain, things that change, reorganizing of the cortex, and even how it changes our being, and how we actually focus on that into some form of instructional methodology. How do we teach this? How do we teach a clinical pursuit to try to treat these patients? So my name's Dave Copenhaver, and we run a large center at UC Davis. It's called the Center for Advancing Pain Relief, and it was a cool idea. It was a thought that we could have like kind of a large kumbaya hippie commune at the university. And the idea was that there was a lot of people studying pain, pain from all different perspectives. There was people in the law school, people in the vet school, there was concerns on the public health side, and we had a great idea that we should all get together and talk about it frequently. And the center slowly developed, and it was really recognized under the aspect that what Bennet mentioned earlier, and what the other talks really touched on, is the fact that pain management, the reason why it's such a, it's an orphan, is because in and of itself, it's part of every discipline. Orthopedics, neurosurgery, primary care, but yet it never had its own home. It's never had its own discipline, and it was kind of relegated to a fellowship kind of subpopulation within anesthesiology and physiatry. So as part of our center, we have neuroscientists, we have neurosurgeons, physiatrists, we also have therapists, behavioral medicine experts, acupuncturists, addictionists, all as part of the group. In addition to that, we also have legal counsel and some very interesting aspects of how to look at this from a sociological perspective, and that has some interesting points in part of the narrative. So that's a little bit about the center. And from that idea, the citizens in the state of California, we had the same problems you guys have in Texas, and we needed to find a way to educate ourselves and the workforce. So telementoring, or at least in some way leveling the playing field with technology, was one way of doing it. We've, not to put a lot of salsa in our tacos, but we have a little bit of guacamole, is the idea that we, as a university, had the belief and thought that we had some ideas on how the science of learning takes place. So nobody wants to sit for long periods of time and sit in a car ride for 8 hours, when we can get there light speed. Or as Jerry Brown, our new governor, he wants to create the new light rail. We have the rail. Get to LA quick from San Francisco. Well, the point is, how can we learn quickly? So high yield strategies, short periods of time, but with very important curriculum, kind of designed for the people, by the people. So it's the primary care docs curriculum, but also nurse practitioners, PAs, even the front office staff that say, Dave, I get phone calls from the pain patients to the clinic, and there's so much despair, I don't even know how to handle the phone call. So something to think about. I'm a believer in the tell them what you're going to tell them, then tell them, and then tell them what you told them. So we have a little bit of a menu. We're not going to follow it exactly because in the interest of time. So I'm going to skip here briefly and just talk. It's a little bit about ECHO and the strategy, and I'm not going to go too much into it. How many of you have heard of ECHO? Program ECHO. So I won't go into its inception and development in New Mexico and other disease models, the idea that telementoring and use of technology works, it's helpful, and certainly it helped in the liver disease population, and could it be transitioned into chronic disease states like pain management? So certainly that's the thought process, the end goal, effectively treating chronic, common, complex diseases. And can we do this by monitoring outcomes and demonstrating success, partnering with our community? So educating folks on these strategies. How do we educate and how do we think of trauma therapy when it's applicable? How do we risk stratify patients? How do we uplift our workforce? Well, it's no shock, I'll tell you, the interesting aspect, there's a lot of great things in California, but we have some dubious distinctions too. Some really kind of, we don't want to talk about them. But I'll tell you, when talking about the narrative of opioids, here's some crazy, very interesting facts coming out of the law school. So how many of you have heard of Bergman versus Chin, that case? Nobody, but we'll talk about it briefly. It's one of the very first landmark cases, happened in 1998, where a physician was working with a patient in a skilled nursing facility, was treating the patient for pain. Actually, the patient was getting fentanyl patches, things like this. But in the end, the patient passed, and the family felt that the patient wasn't managed appropriately. And Michael touched on the idea of the undertreatment of pain. The thought process here is that it certainly didn't seem that the patient, or at least the practice, was negligent. So under malpractice, there wasn't a lawsuit, but actually under the elder abuse statute, there was. So it set a precedent, and this was in '98, that there was a potential to be sued for the undertreatment of pain. And certainly all physicians and other people in the circle of care were saying, I'm compassionate, and compassion means I have a nice bowl instead of mints, I'll have oxycodone at the front of the clinic, and you could certainly come through. And you know, there's a lot of great data on Press-Ganey scores being incredibly successful to the physicians that prescribe more Dilaudid, because Dilaudid equals good Press-Ganey scores. So the thought process is certainly, if I'm compassionate, that I certainly would give oxycodone. So the pendulum starts to swing. Even before that, in 1991, there was a landmark. This was really the first case, a $15 million payout in North Carolina with a patient by the last name of James who was suffering from prostate cancer. Also, this was a negligence issue for the undertreatment of pain. What happened was really an over-reliance. We heard all the discussion with Manu, who presented the data on the early history of opioids. The fifth vital sign started to come about. I don't bash the fifth vital sign. There was an advocacy and understanding to treat pain patients. It was important. And Ken Kaiser was at the VA. He's faculty over at UC Davis and certainly took at it. But here was the difficulty. We raised the awareness, but there was really not much we could do about it. So there was an alarm raised, but there was no understanding on education, on assessment, evaluation, treatment, none of that. So problematic. We raised awareness with no real tools. Gets even more shocking and astonishing. Recently, we just did some data on the USMLE exam, the U.S. medical licensing exam that all medical students in allopathic schools in the country take in order to get a license. Well, on the test, pain is, our hypothesis was that there wasn't going to be much on pain. You know, they're not going to have one question. In fact, we were working with another good colleague of mine, and he's from New York, and he's at our institution. He said, what are you talking about? There's not going to be one question on pain. I guarantee you, Dave, not one. Well, we looked, and pain was all over the exam. We thought, you know, and we were actually allowed to study the test in the locked confines in Washington, D.C. They don't want to let any of the test questions out. It's kind of like, you know, insider trading. And we reviewed the questions. Well, pain was everywhere on the exam, but its effective management, treatment, and the context, which is key to what Bennet was mentioning, was nowhere. So it was a very interesting, enlightening perspective that, and I'm a humble graduate of the University of California, only at Los Angeles, and I could tell you in 4 years that the amount of pain education I received, and maybe many of you would say the same, was about 30 minutes, and it was actually probably a slide on the biology of pain. So certainly there's a huge deficit, and how could we expect that anybody in the primary care workforce or any workforce would have any of the tools or the systems in place to help them? So first shot across the bow, understanding pre-licensure, changing in curriculum would be key. We then started looking at developing pain competencies. Shockingly, maybe not, now that we're talking about all the deficiencies, there was no competencies in pain medicine established in the literature. What does it take to demonstrate competency in pain management? So those had to be developed, and we created a large kumbaya that happened to meet in Sacramento, and many of the thought leaders in pain management, both from the international societies as well as domestic, came and lent to that. So changing the primary care workforce was key, and we wanted to shift and bridge the knowledge gap, which was partly what is Project ECHO, but a new kind of I-Ching Darwin. We changed a lot of it in the sense that we were developing strategies that are high yield, quickly learned, and also topics that people wanted to learn. That was key. So we partnered with the Betty Irene Moore School of Nursing because it's not all about the doctors. In fact, it's not about the doctors. It's about the whole group of everybody taking care of these patients. Betty Irene Moore, her husband, Gordon Moore, founder of Intel, donated on her behalf a great philanthropic gift of a premier nursing school, just opened. And a really forward-thinking dean, Heather Young, partnered with us to develop schools of health specifically around pain management. So we work with Heather. The Center for Health and Technology was a gift from the state, so we were well poised to use the landscape of technology. It's a large building with multiple different conference centers to be able to communicate across the state. So we started using this as a strategy to develop our telementoring program. Very interdisciplinary, 60-minute sessions. How many of you participated in ECHO programs, have actually participated? So there's some. It's a 60-minute program typically, and in the 25 minutes of an interactive didactic session, we do audience response. We ask questions. You can log on with your cell phone, answer yay or nay, kind of Caesar Augustus on certain questions. It interacts with our cyber audience, and you kind of get a sense as to having an active mind, because it's usually done at noon, so people are eating, but at the same time learning. And then we have interactive case discussions, and we've worked with up to 15, 20, 30, 40, 50 or more sites across the state, from the Oregon border down to Los Angeles. The curriculum varies, and it can be expansive, and this is just a very simple broad scope. But what I would tell you is we do have discussions on cognitive behavioral therapy, trauma therapy, but more importantly, we've written some great books, not authored, some of them not, there's a great book that's authored by my colleague Scott Fishman that's called Listening to Pain. Actually, how to, and he's a psychiatrist by trade, how to actually have a conversation with someone that has chronic pain, not for 5 years, but they've had it for 20. And it's much different than other patients. So we actually start by how do we have a conversation first, and then we dive into the other concerns. Tapering methodologies, the use of naloxone, and in whom and how, and many other things that we kind of wonder about. In our state, of course, even marijuana, and what should I do? The schizophrenia between state law and federal law, and what does it mean by prescribing controlled substances? So a number of different curriculum topics. We've had some good success, and like I said, I'm not here to put a lot of salsa in our tacos. I'm here to celebrate all the other organizations like the Weitzman Institute and others, and Bennet Davis, who are doing this, because it certainly has a great track record. Many of our participants demonstrate, yes, it's changed the patterns of how I prescribe opioids, and yes, I would taper patients. You know, it's very easy to start opioid therapy. There's they might say, you know, I used to have a bowl of mints and oxycodone back 10 years ago, Dave. It's easy to start patients on opioid therapy. It's much harder to taper them. And secondarily, is there a pause in when you're going to start opioid therapy? Taking pause and understanding risk stratification and who is the appropriate patient. I'm not here to say there's a moratorium on opioid therapy. What I am here to say is that we should risk stratify, and there's shared decision making. Participants gain more confidence. It certainly was helpful in gaining knowledge, skill about treating patients with pain. Now, many people would come into the clinic and say, oh, I have my panel and I have my list, and look down the list, how's my Wednesday look? Oh no, I got these folks coming in. I feel so dissatisfied with my job. And it was found out that, yeah, it was problematic. It was becoming comfortable with the uncomfortable. And that's the goal of the program, becoming comfortable with the uncomfortable. And certainly that was what we tried to achieve. A lot of testimonials, and certainly. But here was the difficulty, is we expected that there would be this force multiplier effect. We thought that we would be training individuals within their specific clinics, and the clinics were uplifted, certainly. But it turns out that there wasn't the champion. It wasn't the dojo, you know? It wasn't the jujitsu that we were looking for, the expert. And there was a lot of great information, so we decided to create a secondary program really because it came from or born from the appetite of the participants. So we created a primary care pain fellowship. And the pain fellowship is similar to ECHO, but different. And I'm going to actually just switch to this slide that puts them head to head here. ECHO is a one-year program. T3, or Train the Trainer, is a one-year program. But the difference here is key. They actually come to hang out with us 2 weekends in a big, intensive CME course. We have 17 fellows. As soon as we opened it, it filled up. And they come to hang out with us for 2 weekends in Sacramento. And I pair them with a pain specialist so they can phone a friend. The pain specialist phone a friend is a great way because over the year, they actually have a mentor. And that mentorship is key. And then we also hold virtual office hours, all separate from the typical telementoring sessions that are still available. So it kind of gives a sense that we're training trainers and champions. So certainly it's all CME approved. There's a number of things that we offer. There's a cost to it, and I'll tell you what happened with this. Originally, we had the California Healthcare Foundation was funding our program. Out of when funding slowly finished, we transitioned in Medicaid or other managed care insurance products, decided that they liked it so much that they would pay. And we had to create a reasonable fee for the number of clinics, and we varied over the years. Our goal isn't, we're a humble Birkenstock-wearing clinicians at UC Davis. The funding isn't necessarily to establish an emporium. It's actually, in a way, to allow access. So our goal, certainly, we're in the process now of developing an avenue for legislation to support these programs. Partnership Health Plan was one of our largest foci. They helped tremendously. Bob Moore is the CEO, a wonderful partner. He started looking at this and said, we want to participate, and did so for 4 years. Many of their clinics, over 20 clinics participated. They wanted to require justification for high-dose or expensive opioids, escalation of high-dose opioids, and justify all prescriptions for stable high-dose opioids. So they wanted to look at, can we stop escalations, kind of rein in new starts, or really examine who they're starting opioid therapy in, and get a thought on diversion. By the way, I would tell you that many managed Medicaid products, in this case Bob's, was very analytical. They had a lot of data. And the unintentional overdose death story, it's just that. It's unintentional. And many of the patients we've seen have had dose is certainly correlated to escalated risk when it comes to that unintentional finality. So certainly it was important to their organization. He demonstrated, let me see if I have this here, certainly savings in opioid drug costs. So out of the box for the regulators, the return on investment was key. And I didn't throw up a lot of different slides on finances, on finance, but there was a reduction in great savings in initial opioid prescriptions. They had some other fallout. Criminal justice system, improved social stability, workforce productivity. They really felt that those were important employees for the community. And there's strategies to try to measure those outcomes in the small, specific rural communities where their clinics are located. It would open appointments for other conditions and certainly reduce emergency room visits. That was the thought. Now, when I was asked to kind of have a nice segue to give this conversation, we've heard a lot about value-based care. And you know, the climate has shifted as the changes have occurred in politics. Climates have shifted. Tectonic plates are moving. But what I would tell you is that value-based care certainly lends itself to epics or continuums of care. And we're dealing with chronic disease, so it makes sense. I would say that there's a couple strategies of how this could work, and I'll give you one. Integrated practice units are key. I run a secondary, have another hat where I'm a cancer pain doc and palliative care doc at the cancer center. There are archetypal patterns, just like what Bennet was mentioning, Dr. Davis, of the fibromyalgia patient, or as Clay Johnston was mentioning, the knee surgery patient. Those patients have specific needs, and there can be a cycle or continuum of care in the perioperative experience for the knee patient or for the fibromyalgia patient to build around them for that specific archetypal pattern. So having integrated practice units based on disease state, which allows them to assess outcomes and costs, and then you can certainly then use information technology to help leverage some of that. And we could talk more about that, and I know in the interest of time, I'll try to finish up. So certainly IPU models, multidisciplinary teams, that would lend to the final thought on how to have a reimbursed model. And it turns out, if we just take the example of spine surgery, if you examine spine surgery in the United States, it's a problematic endeavor. Never mind the fact that we're chasing pain, and certainly offering spine surgery in just the suggestion from pain alone, not having other objective criteria, motor weakness, sensory loss, other thought processes that go into making the criteria to decide to operate on the spine. But having better success, and what would that mean? Well, certainly it would mean creating some form of a care model built around that archetypal patient that's a potential candidate for spine surgery, which may include behavioral medicine at the very beginning. We know that if patients catastrophize early or have concerns early, their surgical outcomes are poor. So certainly tuning them up prior to surgery, if surgery is even going to be an offering, would be helpful. Then secondarily, not being reactive, but being proactive. And that's building the cycle of care around them. That would be the physical therapists, the behavioral specialist, the pain physician, the surgeon who communicates with the pain specialist, et cetera. It starts to create more of a village mentality, what we've been lacking in medicine. That's sometimes often siloed. So I mention this just as an aside. And I'm thankful to all of you for coming to really kind of look at this from a fresh new perspective of how we're going to change the face of pain management. Our team at UC Davis are the folks here, and look forward to entertaining questions or the panel later today. Thanks again.